Today also we'll continue to do discussion on CPT introduction part. Then we'll move on to the section one, E&M. So in CPT we reviewed the sections of CPT, how to find a code with CPT index and the sections. So today we'll look at the modifiers. Please put a heading modifiers. So in brief, we have the modifiers on the very first page, the cover page, backside of the cover page, the modifiers, there's a list, modifiers 22, 23, 24. So what is modifier? Modifier is a two character code or two digit code. The characters can be alphabets or numbers, numeric. Sometimes alpha plus numeric. So when you say 22, which is totally numbers, if you look at here, E1, upper left eyelid, that is alphanumeric, and you have some modifiers totally alphabets like GG, GH, LC. So these are the modifiers. So modifiers are two character codes that provide additional information about particular procedure. That is the definition of modifier. If you go to Appendix A, so where is Appendix A? So here is Appendix A, modifiers 969, page number. So here you have complete, detailed information about each and every modifier. So a modifier provides the means to report or indicate that a service or procedure that has been performed has been altered by some specific circumstance, but not changed in its definition or code. This is a lengthy definition, but please understand, modifiers provide additional information about particular CPT code or procedure. So let us look at one modifier to give an example how we are going to assign modifier for a CPT code. Yeah. So yesterday we found code for appendectomy, right? What is the code for appendectomy?
44950
44950. So there is a code.
44955.
There is a code. So appendectomy is surgery, right? Major surgery where they open the abdomen and they cut out the appendix and they close the abdomen. So typically it takes about 45 minutes for complete to complete entire surgery, right? So sometimes what happens, one in maybe 100 patients or 1,000 patients, what happens because of some reason the surgery takes about 2 hours. It happens, right? Because of factors, health factors that affect the patient's health. What happens, sometimes the surgeon opens the abdomen and inside there are a lot of adhesions. So surgeon has to work hard to locate the appendage to cut it out. That's what it happens. Now 44950, we typically apply the dollar value is, let's say, $10,000. That is for typical surgery of 45 minutes or 1 hour. But now in this case, the surgeon did the surgery for 2 hours. Yes, the surgeon has to utilize his increased effort, higher skill, then the time duration also increased, right? 2 hours. Now surgeon says, I need more payment. So due to the difficult surgery. So how do you indicate 22? This is how you have to assign modifier. Hyphen 22. So what is 22? Increase procedural service. So you have to read entire description. Now when you assign this and when you submit this code to insurance, the payer understand that, oh, this is increased procedure service, and they review the record and increase the payment by maybe 20%, 20%, depends. That's how it happens. So this is the meaning of modifier, the utilization of modifiers. So without assigning appropriate modifiers, your CPT coding is not complete. You should not only look at the codes, but also modifiers, very important. For example, I'll take another procedure. Um, there's a fracture on the femur, fracture of femur. Then the closed reduction was done. That means plaster of Paris was applied. Let us say the code is, this is a code for the closed treatment of fracture of femur. I'm not putting the complete code. So this is, so let us suppose this is a code. On the right side, femur, right femur. This procedure was done on the right femur. So there are modifiers that indicates the right side. RT. When you put RT, that means this procedure was done on the right side. If it is done on the left side, we put LT. So so we have the modifiers for laterality also. So this is left side, LT is left side. Similarly, RT is for right side. So in case this procedure is done on both sides, so we have a modifier 50, bilateral procedure. For example, if it is done on the both sides, what you can do? You can just put 50. So please go through the modifiers list and understand to the extent possible. But we're going to have detailed session on these modifiers. All right. So your CPT code with the help of modifier, that's gonna complete your CPT coding. All right. So today, let's start the first section, that is evaluation management. So when you say evaluation management, there are two tasks, right? There are two tasks. One is evaluation, and one of them is management. So when you say evaluation, we are talking about the evaluation about the patient's health or patient's disease condition by the provider. Evaluation is assessment of patient's health or patient's disease condition by the provider. So, and management. What do you mean by management? So, management, the word we'll use it in our day-to-day activities, right? What do you mean by management? Management is,
How to address the
mhm,
assessment?
yes. What else? So we find, yes,
What procedures we have to give to take care of
yes,
that disease?
yes. So when you find the issue, how to make it better? We always, we try to make things better, right? That is management. So improving, making it better, that is management. So in the hospital setup, the same thing is done by the provider for the patient. So let us look at we let us look at the example. Okay, these case scenarios, case studies. You've gone through these case studies for all the chapters, right? So this is what, this is evaluation. This is evaluation. So here evaluation, how the provider is evaluating the patient's condition by taking the history. The first step in evaluation is, please make a note. The first step in evaluation is taking the history of the patient. Subject to, yes. The physician takes history. What is the chief complaint? When the complaint started? What is the duration? What is the context? And what is personal history? What is family history? What is your occupation? That is history taking. The first step is history taking. And the second step is objective assess. Examination, isn't it? Examination. So, like general examination, systemic examination, including head, eyes, ears, nose, throat, lungs, heart, extremities. This is examination. So, history taking plus examination. So both make the evaluation part. Now, the management. What is management? So it is MDM. So history, exam. The third one is MDM. Management means MDM, medical decision making. Medical decision making includes assessment. So this is what assessment is: making a provisional diagnosis and ordering tests, also reviewing the results. Let's make it here. Assessment includes diagnosis, order and review tests, order tests and review test results. That is assessment. Based on the history, examination, and the test results, the physician makes a final diagnosis, isn't it? Now, what is plan? Plan includes the treatment plan. Treatment. Treatment can be medication or procedures. Procedures means it can be a medical procedure or surgical procedure. That is plan. So this is your ENM, the components of ENM. This is MDM. So in this is MDM is very critical portion, medical decision making. Now, so if you remember when we started these case studies, I told you that no, these case studies they're going to be useful for you when you start CPT coding also. Now in these case studies, you're done your ICD part. Utilizing the same case studies, you're going to assign ENM codes. Now ENM codes, what is the purpose of these ENM codes? To understand what is the level of service that is done by the provider, because it's like a consultation, right? Consultation has a different meaning in US healthcare, but generally we call it consultation. So consultations has to be paid. So I'll give you a couple of scenarios. So um, for example, in India, the orthopedician, whether a patient is new patient, established patient, the the, the visit fees is same. For example, 1,000 rupees or 1,500 rupees. That's it. But in US it doesn't work like that. In US, the if it is a new patient, the payment will be higher, and if it is um, established patient, the payment will be very less. That's how it works basically. On second criteria, same orthopedician in India, whether it's a simple problem or severe condition, the payment is same because the payment is collected upfront, right? 1,000 rupees. But in US, no, it's a different model. Like if it is a simple problem, the payment is less. As the complexity of the problem increases, the payment also increases because the MDM is also increasing. If the problem is simple, MDM is very simple, but if the problem is very complex, the MDM also becomes complex. That's the reason the payment in US healthcare, the physician's fees for ENM services is based on complexity of MDM. That's what you need to understand. So also the payment also based on differs from place of service to place of service, place to place. So let us discuss what are the factors that contribute that affect the E&M service assignment. The first thing you should learn is POS. What is POS? Place of service. Please make a note. POS means place of service. So where a patient is examined, where E&M service is provided, that is the place of service we're talking about. All right. So in your CPT, on PDF page number 5, you have the place of service codes. These are the places where patient care takes place. 0102 pharmacy, telehealth, school, homeless shelter, and we have almost 2 pages. There are codes from 01 to 99, but they're close to 50, right? So I'll give you the important ones. You don't need to remember all this, but you should remember at least for the codes for 2, 3 place of services. So this is important. 11, office. Please make a note. The important places of service. Number one is 11, office. 12, home. And the third one is 21, inpatient hospital. 22, on campus outpatient hospital. 23, emergency room. 31, skilled nursing facility. Yes, these are the important places. Where you are going to assign, review the codes for this place of service. All right. And this is the first one we are going to review. 11, office. Office means physician's office or clinic, outpatient clinic. That is office here we're talking about. So place of first thing you should know is place of service, very important. The second is new patient versus established patient. We have a clear definition. What is new patient? What is established patient? New patient is one who has not received services in the last 3 years. That is new patient. Established patient is the one who received services at least once in the last 3 years. That is established patient. So here, the 3 years window period is very important. Patient was here. I'll give an example. Patient was here in the clinic in 2020. After that, he never returned. But today he is here. The patient is here. The same patient. His last visit was in 2020. Now today the patient is here with pain in the leg. So is this patient new patient or established patient?
Established.
New.
Because the window period is 3 years.
Three.
In the last 3 years, the patient should receive once, at least once, the treatment. So this patient's visit was last visit in 2020. So this patient is new patient.
Sir, when you say new patient, is it with that particular doctor or is it with that particular hospital? So let's say if we have a Cloud9 in Bangalore, so let's say somebody visited there and then let's say she went to a gynecologist the very first time and probably after 2 years she went to a physician within a three years of time. So will she be a established one or new patient for that particular doctor?
Yeah,
So I mean, say with respect to your saying hospital, or is it with the provider?
yes, that's a good question. So it is with respect to the particular specialty. It's the same hospital, but we're talking about the particular specialty. So it's now we are talking about orthopedics. If the patient has visited, because we are initiated this discussion about particular place of service 11 clinic. Imagine the clinic is orthopedics clinic. Now you have only one specialty because it's orthopedic clinics, only one doctor, orthopedician. So here it's about the orthopedics. But in your case, for example, it's hospital. Then it is we talk about the specialty.
Okay, but the
So
doctor
the
can be different. But
different.
the doctor, okay,
Yeah,
got
but
it.
in the same specialty, again, whether it is the same specialty, for example, it's a big hospital where you have multi specialties, right? Orthopedics, gynecology, dermatology. The patient is continuously visiting every 3 months to one or another specialty. Now, again, we are talking about one specialty, for example, dermatology. In dermatology, his last visit was 2020, and last month he visited orthopedics. But for dermatology, the patient is new patient again, because for the specialty dermatology, in the last 3 years, the patient didn't receive care. And within the dermatology, for example, there are three dermatologists. Let us take a second scenario. It's a hospital, they have different specialties, and in dermatology, there are three doctors practicing dermatology. Last year, the patient visited dermatologist A. This year, patient is coming, dermatologist A is not available. Is the patient is seeing dermatologist B. So this patient is established patient because it need not be the same physician, but any physician within this specialty.
Okay, sir.
So this definition is applicable for same specialty, could be any doctor, any provider. So established patient, yes, the same 3 years window period. If the patient visited at least once in the last 3 years for the same specialist or any doctor in the same specialty, but it should be within the same facility. That's important. All right. So you must know to assign ENM level codes. First thing you should know is the place of service, very important. The second thing is in case of outpatient, you should know whether the patient is new or established patient. All right. Um, okay. But in case of IP, inpatient, if the patient is inpatient, admitted in a hospital, so we count initial visit also as subsequent visit. What is initial visit? The first visit by the provider to the inpatient. That is initial visit. Maybe on the same day of the admission or next day, whatever. But for example, patient is admitted, orthopedician is visiting the patient on the day of admission. That is initial visit. And the second day, third day until discharge, there are subsequent visits. So your ENM codes depend upon the visit type. This is called visit type. In case of OP, is it a new patient or established? In case of IP, is it initial visit or subsequent visit? Now, the third important element is MDM, medical decision making. Very important. So before start assigning ENM levels, you should know these three things. You should ask these three questions. Then only you'll be able to assign ENM codes. All right. So let us go to the ENM codes, the very first code. So the first place of service in the discussion is office or other outpatient services. This is the place of service we are talking about. Now the second thing is we are talking about whether the patient is new patient or established patient, because the codes are different for new patient or established patient. Now, if it is a new patient, we have four codes: 9N202, 9N203, 9N204, 9N205. So let us see um, the codes. 9N202. Anybody wants to read the description? 9N202.
Office or other outpatient visit for the evaluation and management of new patient which requires a medically appropriate history and or examination and straightforward medical decision making. When using total time on the date of the encounter for code selection, 15 minutes must be met or exceeded.
Yes, this is the total description of 9N202 code. In this, you have every information. You know, the place of service. This is office, and with the new or established, also in this new patient, and the MDM portion. The component history and examination is also mentioned. At the same time, the level of MDM is also mentioned. MDM, medical decision making level, straightforward in this case. And time is also mentioned for 99202, that is 15 minutes. So the code, ENM code, will have all the elements that are required for assignment. Now, similarly, let us look at 99203. You just pay attention, read 99203, and let me know the difference between 99202 and 203.
There is a time difference over there, 15 minutes, and here 30 minutes.
Excellent. That's the difference. Difference number one. What else? So I put it in.
MDM is low over here.
Yes, MDM. There's a difference in MDM also. So here 99202, it is straightforward MDM, and 99203 is a low level.
Yeah, it's recorded.
So when you say straightforward MDM, it is very simple case. Simple case. And the complexity is increasing. MDM is all about complexity. The straightforward MDM complexity, whereas low level MDM complexity. So, yes.
So, sir, I
Mhm.
have one question.
Yeah.
Sir, like here, like the straightforward MDM, for example, like the diagnosis is clear, like the person, the patient had like what, like anything like a hypertension, for example.
Mhm. Yes,
So this is called statewide.
correct, correct. It's all about diagnosis. Whether it is simple
Okay.
diagnosis, simple disease, or with complex disease. That's the reason if it's a simple disease, physician took only 15 minutes to clear the patient. But here, because the complexity is increased, so physician has to spend 30 minutes with the patient. That's the difference.
Okay. Okay.
So imagine for this case, an example is simple throat pain. Throat pain that started only yesterday. Healthy patient, 30 years old healthy patient with throat pain, which started only last night. Not even throat pain, discomfort in the throat. That's the kind of problem in it is. Or abrasion, minor injury, which doesn't require any treatment. So most of the conditions here heal on their own, doesn't require any tests or doesn't require any medication. Those are the kind of conditions. Here, 99203, throat pain. So it requires some attention. Maybe test may not be required, but some medicines like paracetamol, OTC, or the counter medication, isn't it? Now coming to the next level, 99204. What's the difference here?
Moderate level in 45 minutes.
Yes, the
Evaluation
MDM
time.
MDM is increasing further. Now it is moderate, higher, still higher problem. The time is also increasing. So if you take the same throat pain, now the first day it was just discomfort in the throat. So it was straightforward MDM, no tests, no medications. And after next day, patient is coming again for the same. Now throat pain is increased. No tests, but paracetamol was given. That is low MDM. Now 204. The patient is coming again next day, not relieved with paracetamol. Throat pain is increasing. Patient has fever, running temperature, and not able to take anything. Now the problem is increasing. Now what the physician has to do? Do the test, throat swab, blood test, and start antibiotics. That is moderate level. Yeah. Any questions?
So just a swab test, or we do the test for the strap throat and all those things. We will come
Yeah.
in the mod, right?
Correct. Correct. If you do any tests, and also if you are giving antibiotics, then it is going to be moderate. The same patient, but every day is coming with a different level of problem because now 205. What is 205?
MDM is high level.
Yes, MDM is
It's
high
for
level, and time is also increasing, 60 minutes.
60 minutes.
So this is 99205 is like life-threatening situation. Patient has to be admitted. Treatment is not possible in outpatient setup. So the same patient, because of a very temperature is 103, not able to take anything in the last 2 days, dehydration, and apart from pharyngitis, there is pneumonia also. Patient is breathless. Now you're admitting the patient, and 205. That is high level effect. So the payment also differs. 99202, the first level is $50. 203 is $75. There's $100. This is $150. That's how the payment goes. And if it is established patient, the one who visited at least once in the last 3 years, the same criteria but codes different. So, but here you have five codes 99211. Let us talk about 99211 later. Let us start with 99212. 99212, just like 99202, straightforward MDM, but time is less, 10 minutes.
Sir, just since we are talking about the time, it's out of the topic question. Usually in the US, when we go to the doctor, sometimes we spend a time in the talking and all those things, in general talking, just the regular conversation when we meet with the doctor. So, and here we are talking about the procedures and all those things, but since we are talking about 15, 20, 45 minutes, those also, that hour, especially how long you're spending with the doctor, that also counts.
Um, yeah, I mean, face to face meeting, if it is a face to face meeting or anything.
Still, for example, we just went for, like, we had a throat pain and I went to see the doctor. But before talking to the doctor, I saw a picture in doctor's office and we started talking about that, and that conversation like went for like 35 minutes. However, in according to the rule, it was supposed to be 15 minutes. I just got to know, but since doctor spent 35 minutes with me over there, so those how that will also count, like, or they will just the doctor will just put the code like, okay, this was thing happened and that's it.
Yeah, it's a good question actually. It's a valid question. See, these codes we are assigning these codes with the purpose of submitting these codes to the payer to get paid. That's the purpose, right? That's the purpose. Now, if the patient is paying out of their pocket, the payment methodology is totally different, right? It's a that is different. But here we are talking about the reimbursement, the course, for the purpose of reimbursement to the payer. Now, here, for example, if it's a simple problem, patient is established patient. Now, it's a simple problem, but just they go into a kind of conversation. Then the visit extended to 35 minutes. It is a simple problem, but conversation time spent for the visit is 35 minutes. And the payer is not patient, payer is insurance. Now, by the MDM, well, if you look at the problem, it is straightforward. But if you look at the time, then that is 9 and 2 and 4. So if the physician bills, now, as I said in the example, 35 minutes is spent. If the physician bills 9 and 2 and 4 for the problem, now the insurance, they'll come for the audit. They will see problem is simple, but you submitted based on the time 9 and 2 and 4. So the actual time spent on the problem is maybe it could be 10 or 15 minutes. So you are entitled to get only 9 and 2 and 2, not 9 and 2 and 4. That will be the consequence. So the one
Okay, yeah.
who is submitting the course,
Mhm.
the doctor is submitting the course, right? Doctor billing.
Yeah.
So he's the one while billing. So the doctor, the physician has to consider what is critical to bill. Is it the MDM
Yes.
or is it time?
Okay. Yeah. Yeah, got it.
Now the physician has two options. He has a choice whether to bill on MDM or time. Yes, the payer has given full freedom to the physician. You can bill either based on MDM or bill based on time, but it has to be reasonable. Reasonable. So that's the only requirement to code to bill. All right. So, for example, in your example, let us take an example similar to what you told. Sometimes what happens, this child, imagine, this child is taken to the clinic. Um, Sometimes, counseling has to be valid. Counseling has to be given for extended time. The problem is, for example, the problem is low level. Look at the problem that is low level, but there is a valid reason to provide counseling to the parents based on the patient's condition, say about 45 minutes. If you go by the MDM 98213, but if you go by the time for 98215, if the counseling is valid, yes, you can bill 98215 based on the time. So, because the doctor spent the good amount of time to provide counseling, which is necessary, right? Clinically necessary. So that's how. Yes.
Sir, for that, like doctor will mention the counseling time in the uh, prescription, or right?
Yes, this is
How?
a medical record. Absolutely, you're right. Absolutely. This is medical record. Now the physician has to say at what time, it's a system, right? Software will capture the start time of the visit
Meet.
and
Visit.
stop time of the visit. So visit started at 10 a.m. and visited at 11 a.m. total 1 hour. Now the physician has to write clearly. So had to spend 30 minutes on counseling and coordinating care for this patient, and total time of 45 minutes is spent, whatever, 45 minutes or 1 hour. So
Yeah,
based
for the
on
counseling and therapies, if we go, then they give the very specific time. Okay, this 1 hour or 2 hour you have, that's it. But when we go to the regular doctor, for example, when I was going to my gynec, we used to take a very long conversation, like half an hour, 45 minutes. And that time we were not aware about that. Yeah, but now,
yeah,
yes.
yes, if the provider is billing based on the time, and yes, it must be documented. How much time is spent, how much time is for. If it's a, if you're billing just based on MDM 9213, that's fine. You don't need to talk about the time. But if you're billing based on the time, yes, the physician must document.
Sir, let's say the code is 12345. It'll go along with the modifier. As you mentioned, like 22 is for extra long time. So as a coder, we have to put 22 modify against the code so that the extra time will taken care over there.
Um, yeah, I mean, yes, these modifiers, there are modifiers specific for ENM. There are modifiers specifically for surgery. So 22, that is meant for surgery codes, not for ENM codes, not for ENM codes. So, and yes, there are provisions. There are separate codes to indicate the time taken by the physician is prolonged. We have prolonged codes also. For example, your question, what do you say? Where are we? Where is PDF? Yeah, this is. With a new patient, office visit is 60 minutes, right? 60 minutes. What if, because of some reason, because of valid reason, the physician has to spend 2 hours? There's no code. 9820 is the top, right? But the physician wants more payment because the physician spent 120 minutes. This is the provision. So we have codes for prolonged service. You'll find those codes, prolonged service, and yeah, there's an exercise for you, homework for you, because you're going to read. This is about 50 pages. Entire ENM is about 50 pages, and you're going to read each and every code, the description. So in that process, you're going to find codes for prolonged services, what you call. Yes, we have codes. But the regular checkups, they have given only 4 levels. Now let us summarize. What are the levels of MDM?
Three levels.
What are they?
One is place of service, a second is new patient versus established patient, and the third is MDN depends upon the complexity.
That is
I'm
the
sorry.
evaluation.
I'll put the question in a different way. I'm sorry. What are the levels of MDM? Medical decision making.
Sir,
What are the
yeah,
level?
it's like low, moderate, high.
4 levels.
No?
Please make a note.
Straight wide. Start from straight wide.
Yes. Now, please make a note. There are 4 levels of MDM: straightforward, low, moderate, high. Very important. All right. So I hope you are the the picture, entire picture, how ENM codes are assigned at basic level, right? So now if we move on further, now let us we are talking about this the 99211. There's one code extra, 99211 for established patient. So can you read the description for 99211? Do you find any difference?
Time is not mentioned neither that like straightforward or. The complexity is also not mentioned.
Yes, because it's a nurse visit. The physician is not required. May not require the visit, may not require the presence of physician. That's it. Because sometimes what happens is an established patient, follow-up case. The patient straight away goes to the nursing station and gets, his or her injection or change of bandage, and without seeing the patient, without seeing the physician, patient leaves. That is nurse visit 98211. But the entire visit is provided under the supervision of physician, directly or indirectly. That is 98211. For this, maybe the payment is $10 or $15, whatever. That's how it works. But technically, we have 4 levels of MDM, and based on which you are going to assign the course. Right? Yeah.
So subsequent visit is a follow-up visit.
Yes, subsequent visit is follow-up visit. But so in
But
case of
sir, all
mhm,
but sir,
yes,
all subsequent is called follow up, or maybe different reason also.
yeah.
No.
See, in case of outpatient, we take only new patient as established patient. We count only new patient. For example, the patient came yesterday. Patient was here yesterday. Today is also is coming. That's a follow-up visit, right? And it's a definitely is follow-up
If
visit.
the same, sorry sir, like if the same patient will come after maybe 5 days, so it will go. It will call again the subsequent, right?
Now we don't use subsequent in case of outpatient. We use only established patient, established visit. Because subsequent visit is only meant for inpatient visits. If the patient is admitted, because the physician is
Okay.
making a
Okay,
visit,
got you. Got you. Yeah. Okay. Okay.
so it's a new visit, new patient, or established patient or established visit. That's the only verbiage we are going to use in case of outpatient. All right. So today, what we're going to do, you're going to read only the headings, subheadings. Very important. So how the courses are classified, CPT, ENM courses are classified. You need to understand the organization. For example, if you come to this ENM, um, the table of contents page, you have the guidelines in the beginning, say about 14 pages of guidelines. Once you finish the guidelines, you have the proper codes. Officer, new patient, officer 992022115. Because this is a PDF, it's all in black and white, but if you have a original book, you'll see the color coding. Headings, subheadings, they're coded with color. So this is main heading, office visits. But if it's a hospital inpatient, that is 99221, 99239. Again, based on place of service is changing. Place of service here is office. Here the place of service is inpatient. But again, code assignment is based on DM time. Now let us go to another place of service, emergency department. This is a different place of service. The codes are 992812288. So here, emergency department, there is no difference whether new or established. The codes are same, 998122885. So this is emergency department is very important one. Let us go to emergency department. Please go to emergency department codes.
So, sir, if we
Mhm.
choose the place of service home,
Mhm.
that's not only the case only in the emergency cases, or in general cases it happens also that home becomes the place of service.
For example, if you go to place of service home, where the patient is at home and the physician is visiting a home, then the codes are, if it is a new patient, 993412345. If it is an established patient, 993472350. But in case of emergency patient department, there is no difference whether new or established, the same course. Have I
Okay.
answered the question? Yeah.
I was just I was just thinking like actually this is pretty new for me that I'm hearing that doctor here I never heard except the emergency physician go to home as well and give the services. uh so those are if we are taking talking about the counseling and therapies as well in those cases.
Or it could be of any reason, because every patient, whether the patient is here in the clinic or at home receiving care, and it has to be input in the system, right? So system shows whether the patient is new or
Where he
established
was.
and where he was.
Hmm.
But ultimately, the billing happens. So when you bill, you must indicate place of service, whether the patient was in the clinic or a physician went to patient's home. But it's the same similar submission of claim. The claim form is same CMS 1500 form. In the CMS, because I shared the CMS 1500 form with you, there's a space, there's a field for place of service. For example, you're a physician, you're running your clinic. On request of the patient, you went to patient's home, provided the care, then you want to submit the claim. So you would write that place of service is patient's home. Okay. Then you have to put your code 99341 or 342, depending upon new or established. So please remember, we are talking about coding rules. Coding rules may not be the same as reimbursement rules. When I say reimbursement rules, for example, you're a physician, you're running a clinic, and see, for every service, there should be a license, right? So without license, can we run any operations? No, because when you just walk into any clinic or hospital, you will see a big board giving the list of the scope of services. Have you seen that board? Scope of services. That is based on the license. So if the clinic has license to provide home services, yes, they can provide. But if they don't have license to provide home services, they cannot. So that is reimbursement rule. Technically, if you follow just coding rules, yes, you think that yes, I can go to the patient's home and I can provide. And if you bill, you may not get paid because you're not authorized to provide home services. That is licensing issue or reimbursement issue. So yes, that's how it works basically. So I mean, the facility should look at all the aspects. It's not just coding, but other um, regulatory requirements also. All right. Now, so yes, because now if you look at here, these for these visits, you can start assigning ENM codes, but you have to ask, place of surveys, the new order established, then MDM. You have to understand MDM. All right. So you can ask one question. Um, you have seen this all the cases, right? Did provider anywhere mention straightforward, low, moderate, or anything of the sort?
No.
No, right? Then how we are going to understand? Because the place of service is mentioned somewhere, and patient is new or established, but in all these records, nowhere it is mentioned straightforward, low, or high, moderate. So That is the job of coders. Coders, they have to read, they have to understand whether it is straightforward, low or high, whatever. Okay. Doctors will not write because, like I said, that's the reason we are learning medical technology. We understand how the documentation happens. We also understand the nature of problem. So there is a quantification. We are quantifying the documentation. Basically, what we are doing, we are by reading this, we are quantifying the documentation. We are quantifying the patient's problem, whether it is straightforward, whether it is high. The extension MDM levels, right? We discussed MDM levels. There are 4 levels, and also MDM elements. Now we are breaking down the MDM level. So to break down MDM levels, we should know MDM level elements. MDM levels are elements are problem, data, risk. You remember these 3 words: problem, data, risk. These are the MDM elements. The levels are different, elements are different. Levels are SF, straightforward, low, moderate, and high. These are the levels, they are elements: problem, data, risk. What do you mean by that? As a coder, you should understand what is the problem, what is the data. Problem means the disease, data means what is the workup. Workup means investigations, how much patient's data is available to review. Then risk, what is the risk of the treatment, disease to the patient. As a coder, you have to understand these 3 elements, and you should be able to assign the level.
So, what is risk, please?
Risk is, risk is something bad to happen. If you just take English word meaning, what is risk? Basically, the probability of something bad to happen. That is risk. Now, treatment, when the patient receives treatment or when the patient undergoes some tests, whether radiological or laboratory, because this tests and treatment is aimed at bringing something good, right, to resolve the disease. But in this process, something bad also can happen, doesn't it? Do you agree with it? So that is risk. So, for example, injection is given. In 99% of the cases, patients be all right. But in one case, what happens? There is a swelling, infection, complication. That is risk. So every surgery, every procedure, every medicine carries a certain amount of risk. So the physician has to exercise the assess the risk, pros and cons for every treatment plan, and he has to take a judgment whether this treatment or test suits the patient's health or not. So to carry out that process, the physician has to spend some time. That decides the MDM level. Whereas if the risk is higher, then the MDM level goes up. That's how it is. That's how we look at the risk. Now, to understand these 3 elements, so if you're able to see the screen, in the beginning pages, we have something called levels of medical decision making table. Table 1. So you have to go through this table. You have to understand this table. So you have 4 columns: 1, 2, 3, 4. The first column, it's about MDM level. Straightforward, low. They should have given in the same page. Moderate, high. And these are the elements what I was talking about. Number and complexity of problem addressed at the encounter. So I have done a single word, that is problem. You can highlight this word problem. The second one, amount and complexity of data to be reviewed and analyzed. This is all about data. You can highlight this data word. Third one is risk of complications and or morbidity, mortality of patient management. Risk. So, like I said, the physician will not write is it straightforward, low, moderate, or high. Is the for the coder to understand based on the documentation. What level of problem is it? What is the amount of data that was reviewed? What is the risk of the management? Is understand is the risk of the patient management. So risk of what? Risk of morbidity. Risk of morbidity means risk of getting complication. Mortality, risk of death. Sometimes some procedures they carry death of, risk of death also. That's the reason the hospital, the provider, they take the what do they take before starting the procedure? What is the important step before starting the procedure?
The
Any
consent
surgery?
form.
Consent. So the patient has to sign the consent form. The consent form states all the risks associated with the procedure. Now the patient has to read, understand, consent for all the risks. Then only a surgery can be carried out. Otherwise, no. So please go through this table. Yes, try to understand to the extent possible. Then we'll discuss further. All right. So, any questions in ENM so far? But what I'm trying to say, just keep your ICD 10 CM. Uh, Now spend only 10 to 15 minutes on ICD. You have to spend your full time on the CPT ENM because this is a current topic. I need your full time on this ENM. Yeah.